Well, good morning, everybody. Welcome to Grand Rounds. I'm very pleased to be able to introduce to you this morning Dr. Lynn Cornell. Lynn is currently a consultant and assistant professor at Mayo Clinic. She was born and raised in Minnesota, and after graduating from high school decided to see what the rest of the country was like, and so she went east to MIT to get her undergraduate training. She then came back here and received her medical school training here at the University of Minnesota, and she graduated in 2001, and then she decided to go back east again. And so she went to Mass General for her pathology residency. And at that time, she had a chance to begin to work with Bob Colvin. And this, I think, was very important probably for her career because, first of all, she was able to be on the ground floor of our understanding of IgG4 disease, in particular IgG4 nephropathy. And she also began to work with Bob Colvin in the area of transplant pathology. And in 2005, she started the Robert McCluskey Fellowship in Renal Pathology at MGH. And at the same time, she was a NIH postdoc training individual in transplant biology. And so she worked for 2 years at MGH in those particular areas. And then after that, she came back to Mayo Clinic, and is where she has spent the rest of her relatively short career so far. Her bibliography is quite extensive. She's published many articles in the area of IgG4 disease, in the area of transplant pathology, and some other areas of renal pathology. And I learned last night that she also has a strong interest in birds, which was interesting. Since the institution here has been talking about doing transplant protocol biopsies, Lynn is going to talk to us about their experience in transplant protocol biopsies at Mayo Clinic. The title of her talk is Kidney Transplant Protocol Biopsies, Lessons Learned. So please welcome Lynn. Thank you.
Well, thanks for having me. It's a pleasure to visit and see all the new buildings here too. And I just wanted to say how much I enjoyed my pathology courses in medical school here, and the University of Minnesota has such a strong pathology department and such strong education in pathology in the medical school. So I think about 7 or 8 people from my class ended up going into pathology. And even renal pathology we learned about in medical school, so I really appreciate that. So many of you, I think, aren't involved in kidney biopsies or kidney transplants, but I think some of these lessons can still be applied to other areas of pathology. So today I'll talk about the evolving concepts of the value of kidney transplant protocol biopsies, talk about some examples of recurrent glomerular disease in the transplant, and some causes of late graft dysfunction and loss, especially from what we can learn from protocol biopsies. The definition of a protocol biopsy is a biopsy that's performed at predetermined time points post-transplant and that's unrelated to graft dysfunction or other clinical indication. The common timing of protocol biopsies are implantation, also called time zero biopsies, 1 month, 3 to 4 months, 6 months, and 1 year post-transplant, not necessarily all of these time points, 2 years, 5 years, and 10 years. And most centers concentrate in this earlier post-transplant period, doing biopsies at these time points, up to 1 to 2 years post-transplant. The biopsy procedure is performed by an ultrasound-guided biopsy gun with a 16 to 18 gauge needle. There's a really low rate of major complications. The major complications are hemorrhage requiring blood transfusion, hospitalization, peritonitis due to bowel perforation. Graft loss is very uncommon. And there was a recent study that showed a lower rate of complications in protocol biopsies versus for-cause transplant biopsies. So why do we perform protocol biopsies? Well, for several reasons. They are useful in monitoring highly sensitized transplant patients. So those are patients who have preformed donor-specific antibodies. We can detect and potentially treat subclinical disease in the allograft. Also, findings on earlier biopsies may identify a cause of later graft loss. And commonly, these are used in clinical trials to document outcome and detect toxicity of investigational drugs. So there have been earlier studies, mostly in the 1980s, that involved protocol biopsies in kidney transplants. And these were studies to determine optimal immunosuppressive protocols. These biopsies mostly showed interstitial inflammation, which we now recognize as acute cellular rejection on the biopsy, and sometimes interstitial fibrosis and tubular atrophy. These were mostly done in the earlier post-transplant period, within 1 year post-transplant, because graft survival was not so good back then. But now we have current immunosuppressive protocols with standard induction therapy and standard immunosuppression with mycophenolate, tacrolimus, and prednisone, and we have a very low rate of acute cellular rejection if patients are taking their medications, and good shorter-term graft survival. So what do we use protocol biopsies for now? At Mayo Clinic, we perform protocol biopsies on all kidney transplant recipients, so not just patients who are in a certain drug trial or something, or highly sensitized or at particular risk. All of the patients get protocol biopsies. And at Mayo, we perform implantation or time zero kidney biopsies 4 months post-transplant, 1 year, 2 years, 5 years, and 10 years post-transplant. And at these different time points, we're looking for or expect to see different kinds of diseases. So again, not just looking for acute cellular rejection, which is a really low prevalence. At the time zero biopsies, we see mostly donor disease, although they usually look completely normal. But we can see vascular disease at a baseline that can predict what may be a worse outcome for that graft. Early post-transplant, in 4 months and 1 year, we see early recurrent glomerulonephritis, subclinical rejection, which can be cellular or humoral. Again, a low rate of that, but we can still see that, and BK polyomavirus infection. A little later post-transplant, we see continued recurrent glomerulonephritis. Subclinical rejection can always be present, either cellular or humoral. Chronic rejection we see more later post-transplant, cellular or humoral. And we can also start to see de novo glomerular disease later post-transplant. And then at 10 years, what do we see? Well, this is a new area, and I'll go over this a little bit later. So I'll go over a few lessons that we've learned from allograft biopsies. But first, let's look at what are the causes of graft loss. And this was a nice paper from my colleagues at Mayo that looked at causes of graft loss during a 10-year time period in 1,317 conventional kidney transplant recipients. And there was a total of 330 graft losses. A small percentage of those were due to primary non-function. Another about 10% of patients died with a functioning graft, which is really the ideal situation. And then also about 12% had graft loss before the patient died. So they have to go back on dialysis or receive another kidney transplant. And those patients with the death-censored graft loss are really the ones that we would be interested in improving outcomes in those patients. So specifically, what were the causes of those diseases, or of the graft loss? They determined the cause in 98% of those transplants. And I just want to call your attention to glomerular disease, which was responsible for 37% of the graft losses. So that's a really important thing to consider, especially when people were used to thinking of rejection as causing graft loss. Actually, it's glomerular disease is responsible for a lot of these. So of these 37%, the glomerular diseases were recurrent glomerular disease. 15% were due to transplant glomerulopathy, mostly that was due to chronic antibody-mediated rejection. And a lesser proportion, 6.6%, were due to de novo glomerular disease. And the specific common recurrent glomerular diseases were focal segmental glomerulosclerosis, IgA nephropathy, membranous glomerulonephritis, and membranoproliferative glomerulonephritis. So it's interesting to look at the comparison from transplants and native kidney diseases. In the native kidney disease, the disease starts at some time point in the patient, and we don't know, it's not clinically evident. The patient eventually develops some symptoms or is picked up on routine labs to have some kind of kidney disease, and then receives a clinical diagnosis, eventually may undergo a kidney biopsy for a histologic diagnosis, and then has some progressive disease and eventually may undergo treatment or not. And there is some waiting period here. Possibly the disease may go away. Sometimes membranous glomerulonephritis can go away by itself in the native kidney, or that the treatments are too toxic compared to the severity of the kidney disease, like in some cases of IgA nephropathy. Now, protocol biopsies are a little bit different situation and raise interesting questions. So the disease starts at some point, but the histologic diagnosis moves earlier. So we can see it there before the patients develop any clinical symptoms or any lab abnormalities. So one question is, what do these diseases look like when they begin? And we're starting to answer those questions. And does the histologic diagnosis precede clinical manifestations? Typically, it seems like it does. And then should we treat based on histology, and can we improve the kidney prognosis? And these are things we're trying to figure out for different specific diseases. So I'll go over an example, which we can call the birth of a well-known glomerular disease. This was a 51-year-old kidney transplant recipient who received a transplant in January 2008. The original disease was primary membranous glomerulonephritis. 1 month post-transplant, the patient had surgery for a lymphocele and had an elevated creatinine. The biopsy was done during surgery. Now at Mayo, I think they're really interested in doing kidney transplant biopsies. Anytime that there is any kind of procedure, operation, they're anywhere near the kidney, they do a kidney biopsy. So this patient also had minimal proteinuria, 179 milligrams per day. So what does the biopsy show? Well, usually they look normal within 1 month post-transplant, and here this looks pretty normal. Look at these glomeruli, normal cellularity, and no infiltration of any inflammatory cells. And look at the tubules and interstitium again. Look normal. We don't have any inflammatory cell infiltration. And here on higher magnification, on a silver stain, again, he had a history of membranous glomerulonephritis, so we'd be worried about a glomerular disease. The glomerular basement membranes look completely normal here. Now, we often do C4D staining in the kidney transplant to detect humoral rejection, acute antibody-mediated rejection. But here is a glomerulus, and you can see this granular glomerular basement membrane staining for C4D. And that's not usually what we would see. There is lesser staining in a similar pattern for IgG. And then similar, less intense staining for kappa and lambda light chain, but these deposits are definitely here in the glomeruli. Now, what about the electron microscopy? Well, we saw those deposits by immunofluorescence, but look, we don't see any deposits in the glomerular basement membranes, and the podocytes show preserved foot processes. Here's a higher magnification in case you don't believe me. We don't see any deposits by electron microscopy, and then look, preserved podocyte foot processes here. So in summary, the light microscopy looks normal here. The immunofluorescence showed granular glomerular basement membrane staining for IgG, C4d, and kappa and lambda light chains. Negative staining for C3, IgA, and IgM in the glomeruli. And by electron microscopy, normal with no deposits. So our diagnosis, as we've learned now, is early recurrent membranous glomerulonephritis. Now, in the native kidney in membranous glomerulonephritis, patients present with nephrotic syndrome. So they have heavy proteinuria, low albumin, peripheral edema, and it's very clinically evident that they have a kidney disease. On the biopsy, they have thickened glomerular basement membranes, and we often describe basement membrane spikes that you can see nicely on a silver stain. By immunofluorescence, there's staining of the glomerular basement membranes for IgG, C3, and kappa and lambda. And by electron microscopy, here we see these subepithelial deposits along the glomerular basement membranes, and then also diffuse podocyte foot process effacement. Now, in early recurrent membranous glomerulonephritis in the transplant, we see a different picture. There's no or minimal proteinuria in the patient in normal light microscopy and normal electron microscopy. So we put together a series of 21 patients with recurrent membranous glomerulonephritis, early recurrent membranous glomerulonephritis. These were all within the first 4 months post-transplant. There were 11 protocol biopsies and 10 indication biopsies like the one I just showed you. The time post-transplant was from 2 weeks to 4 months post-transplant. And the proteinuria average was 1.1 grams per day, but it ranged from no proteinuria up to 5.7 grams per day. And look at this, 75% of the patients had less than 1 gram per day proteinuria. So this isn't something where the clinicians would be suspicious for any recurrent disease. By light microscopy, as I said, the glomeruli and all these patients look normal. By immunofluorescence, it showed the same staining pattern with glomerular basement membrane staining for C4d, which was usually the brightest, IgG and kappa and lambda, usually negative or trace C3 staining, interestingly. And by electron microscopy, most of the patients showed no deposits or rare tiny subepithelial deposits. And we actually did a correlation between the amount of proteinuria and the degree of subepithelial deposits and the degree of podocyte foot process effacement, and those did correlate. So you had proteinuria with more deposits and more podocyte foot process effacement. We had clinical follow-up data in all of these 21 patients. None of the grafts were lost. 13 patients developed more than 1 gram per day proteinuria, and they were treated with rituximab, most of them. 2 were treated with ACE inhibitors and increased prednisone, and 2 were treated with ACE inhibitors or angiotensin II receptor blockers only. And all of the patients had reduced proteinuria with treatment. So here is a table that summarizes the features of native and early and later recurrent membranous glomerulonephritis. Later recurrent membranous glomerulonephritis is more like native kidney membranous glomerulonephritis. So the patients have more proteinuria. There's staining bright staining by immunofluorescence for IgG, kappa, and lambda. Staining for C4d is present at all of these stages. C3, as I showed, is usually bright in native kidney membranous glomerulonephritis, but early post-transplant and even later post-transplant, several years post-transplant, the C3 is usually negative or dim. By electron microscopy, we see subepithelial deposits in native membranous and later recurrent membranous, but usually not in early recurrent membranous. And the podocyte foot process effacement correlates with the degree of subepithelial deposits. Now in this patient that I showed you, you can see here's the estimated glomerular filtration rate and the proteinuria. And the patient had, increased proteinuria. Early post-transplant, I had biopsies at these time points. And I'll show you a little bit later, 5 months post-transplant, he had a biopsy, and you can see now the subepithelial deposits are there, and we see brighter staining of the glomerular basement membranes for IgG. The patient was then treated, and 2 years post-transplant, look, the deposits have disappeared, and there's just minimal podocyte foot process effacement. Also at 24 months post-transplant, that's the same biopsy, there is a little bit of staining for C4d. So as we saw before, we can still see that, some of that staining without corresponding deposits by electron microscopy. And IgG, again, is dim, but still a little bit present. So, so here it is a progression of one case. You can see these subepithelial deposits in another case, a diagnosis 4 months post-transplant. 1 year after rituximab, the patient had no proteinuria, but you can see some of these deposits still and thickened glomerular basement membranes. And 2 years after rituximab, the patient had no proteinuria, but look, still deposits, but they're electron lucent. They're all being reabsorbed. So here's some postulated benefits of protocol biopsies in recurrent glomerulonephritis. We can provide an early preclinical diagnosis. There's some pathologic clues to the course of native kidney disease. An early histologic diagnosis may allow more effective treatment, although we don't really know that at this point. And that will require more studies. So studies using protocol biopsies suggest that we need diagnostic criteria for early disease. For example, that first case of membranous glomerulonephritis that I showed you wouldn't really qualify for a diagnosis of membranous glomerulonephritis. In the native kidney, we wouldn't know what to do with it. So we need different criteria because these biopsies show a different appearance of glomerular disease. This is true for lupus, recurrent lupus nephritis, recurrent IgA nephropathy, membranous, other diseases. They all look a little bit different in the transplant. It might be because of the time that we're biopsying them, or it might be because there's a different course of disease in the transplant. And we need multi-center studies based on protocol biopsies to determine histologic diagnosis and how that corresponds to the clinical outcome and the effectiveness of early treatment. So now I'll move on to what's really interesting, I think, is our 10-year protocol biopsies. So the conventional view of late allografts is that the grafts are lost or show late graft dysfunction due to CAN, or chronic allograft nephropathy. And this is progressive interstitial fibrosis and tubular atrophy, which people have postulated is due to chronic calcineurin inhibitor toxicity because nearly all of these patients are on a calcineurin inhibitor, cyclosporin or tacrolimus. Alternatively, the late allograft dysfunction and loss is due to progressive antibody-mediated rejection because so many patients develop donor-specific antibodies, or we're searching for donor-specific antibodies. And in chronic antibody-mediated rejection, we can see here peritubular capillaritis with these marginated cells, and glomerulitis. You can see these marginated cells in the glomeruli, and glomerular basement membrane duplication. This is called transplant glomerulopathy when we don't have evidence of immune complex deposits in the glomeruli. So this is due to chronic humoral rejection, also known as chronic antibody-mediated rejection. So what do our late or 10-year post-transplant biopsies actually show? Well, we started doing transplant or protocol biopsies or enrolling patients in the protocol biopsy program back in 2002. So I looked at the 10-year protocol biopsies in patients who were transplanted between 2002 and 2005. Most of the patients were on this routine triple immunosuppression with tacrolimus, mycophenolate, and prednisone. And I performed scoring using the BAMP 2013 system and also some additional scoring that was not addressed by the BAMP system. So what did the biopsies show? There were predominantly glomerular and vascular changes, mild or no interstitial fibrosis and tubular atrophy, and a low rate of chronic antibody-mediated rejection. So this is really different from what we would expect to see in these transplants, which, conventional thinking would show progressive interstitial fibrosis and tubular atrophy and features of chronic humoral rejection. So here's something that we can see, which is increased global glomerulosclerosis. So you can see glomeruli, intact glomeruli here, and then look, at least 4 globally sclerotic glomeruli just in this field. And you can define increased global glomerulosclerosis based on what you would expect for the age of that kidney. And Andrew Rule has done a lot of studies from our implantation biopsies representing a normal, healthy population and what degree of global glomerulosclerosis you would expect for that age of a patient here at that age of the kidney. But we see increased global glomerulosclerosis based on that. And also you can look at it if it's more than 20% global glomerulosclerosis, because that's usually what we think of if we're going to accept a kidney from a deceased donor or not. So those are 2 cutoffs we can look at. Here's a PAS vein section, and you can see a little bit of mesangial matrix expansion, and this is in a patient who does not have diabetes. And here's some arteriolar hyalinosis, which is intimal. Here's another example of mesangial matrix expansion in a patient who does not have diabetes. And look, it looks starting to look a little nodular. So it kind of looks like an early diabetic glomerulosclerosis, but this patient did not have diabetes. Here's another example. You can see these nodule formation, again, in a patient without diabetes. But certainly a lot of patients also have de novo diabetes with the transplant, or they had that as the original disease and still have diabetes. And then here you can see intimal hyalinosis of an arteriole and also this peripheral nodular hyaline. And this peripheral nodular hyaline is sometimes put forth as a histologic marker of chronic calcineurin inhibitor toxicity. This was actually pretty uncommon to see in the transplants. So here are the glomerular changes that we observed on 10-year biopsies. There's mesangial sclerosis in a number of these patients, 68% of the biopsies. There were 151 10-year protocol biopsies from this patient population. Glomerulomegaly is something else that was commonly seen, 36%. Focal segmental glomerulosclerosis was present in 18%. Increased global glomerulosclerosis, as I mentioned, was quite common, 45%. But any chronic glomerular change was seen in the majority, 85% of these patients. Transplant glomerulopathy due to chronic humoral rejection was present in only 10% of patients, so that's pretty uncommon. Of course, many of the patients who might have had chronic humoral rejection didn't make it to 10 years. They maybe lost their grafts before this time point. And then only 15% of patients had no chronic glomerular changes. And then we can look at the glomerular filtration rate and the proteinuria, and compared to the normal appearing biopsies or biopsies with normal glomeruli, the ones with patients with focal segmental glomerulosclerosis or transplant glomerulopathy had statistically increased proteinuria. Now we can also look at the histologic changes from 5 to 10 years, and just last week I finished reviewing most of the 5-year biopsies, and these are paired for the 10-year biopsies. I only have 127 because some of these were checked out to other people or whatever, so I have to get these biopsies reviewed. But look at the increase from 5 to 10 years, increase in mesangial sclerosis, increase in glomerulomegaly, increase in focal segmental glomerulosclerosis, and increased global glomerulosclerosis. These were all statistically increased from 5 to 10 years. So these are the progressive changes. Transplant glomerulopathy was present at about the same rate in both groups. Arteriolar hyalinosis was progressive, also very common on the 10-year biopsies, but not so common on 5-year biopsies. Moderate to severe arteriosclerosis was also progressive. And then look, interstitial fibrosis and tubular atrophy was moderate to severe, was present in the same rate at 5 and 10 years. And again, these are paired biopsies, so it shows that these are not progressive lesions. Some lesions are progressive, some are not progressive. So here is a graph that shows different trends in kidney graft histology over time. Minor changes, which are pretty normal looking biopsies. You know, many of the biopsies do show minor changes. Interstitial fibrosis and tubular atrophy is present in a pretty low rate at all times post-transplant when we examine them. Also, chronic antibody-mediated rejection is present in a pretty low rate. Diabetic glomerulosclerosis or diabetic-like glomerulosclerosis with mesangial sclerosis is present in increasing frequency, especially at 10 years post-transplant. And arteriolar hyalinosis is a progressive lesion present at increasing prevalence. We can also look at the progression of the percent of globally sclerotic glomeruli compared to implantation and at 10 years. And at implantation, in the number of biopsies most of them do not show increased global glomerulosclerosis, but at later post-transplant periods, at 10 years, you see more of the biopsies showing increased global glomerulosclerosis. We also looked at, I mentioned this mesangial sclerosis that we saw, and this seems to correlate with the body mass index at 1 year. So both in patients who have diabetes and those who don't have diabetes. So you can see with increasing body mass index, we have more biopsies that showed mesangial sclerosis. We can also see increasing mesangial sclerosis in patients with fasting glycemia, hyperglycemia, here more mesangial sclerosis. So even though patients, maybe they haven't been diagnosed with diabetes, they still can have a little bit elevated fasting glucose level. So the conclusions from these 10-year biopsy data, most 10-year protocol biopsies show chronic histologic changes, particularly in glomeruli, that are not accounted for in the current BAMP grading schema. So we've proposed some new BAMP scores, and the BAMP scores were mostly developed to address rejection, especially acute cellular rejection, and then later antibody-mediated rejection was incorporated into the BAMP scoring system. And for different clinical studies, I think we should use some new BAMP scores that take into account these later graft changes, which are mesangial sclerosis, glomerulomegaly, focal segmental glomerulosclerosis, and global glomerulosclerosis. Also, moderate to severe interstitial fibrosis and tubular atrophy and transplant glomerulopathy are uncommon in functioning grafts at 10 years. And this argues for an alternative viewpoint of the mechanism of late graft injury. And from 5 to 10 years and beyond, the graft is confronted with new pathologic challenges that likely we are not addressing adequately. And especially, it's really, since we haven't done protocol biopsies between the 5-year and 10-year post-transplant time points, we really don't know what's going on during that time point. We do them earlier post-transplant. So we've actually been talking about changing our protocol biopsy timing to be at 4 years, 7 years, and 10 years instead of 5 years. And then we'd be able to look at those progressively every three years and see what the changes are. And what are the things we can do for the patients in this interim? Well, reduce the body mass index. That's always hard, especially when we have donuts for breakfast. And, reduce diabetes, these kinds of things. Maybe we can work on patients with these things rather than worrying so much about rejection. So on the kidney transplant protocol biopsies, we can recognize subclinical disease. The recurrent glomerular disease may show different histologic patterns from the native kidneys. We can determine causes of graft failure and late graft injury. And in all of these, pathologists play a central role. So I've been really fortunate to be able to work with my great colleagues too to get clinical information. But pathologists are so fortunate to be able to see these biopsies from these patients and really learn about the allografts from there. So that's all that I have here. Thank you.
Thank you, Lynn. We have time for questions. Cliff.
Hi, it was a very nice talk.
Thanks.
I'm a pediatric nephrologist, so I don't see a lot of patients with membranous.
Mm-hmm.
I'm just curious what percentage of patients with membranous in your population have evidence of recurrence, and do you have any information on antibodies to Postulated A2 pre and post-transplant relationship to recurrence?
Yeah, so, okay, so the question was, what's the rate of recurrent membranous glomerulonephritis in the transplants, and then how many of them have PLA2R antibodies, and that's an antibody that is responsible for most cases of primary membranous glomerulonephritis. So at Mayo, we have 48% of patients with membranous as the primary glomerular disease recur. And most of those are detected on protocol biopsies, maybe because we're doing protocol biopsies. But 48%, that's pretty high. In the literature, maybe it's 30%, but that's also because those are patients who had that became clinically evident. So it's a pretty high rate of recurrence. Most of those do have PLA2R antibodies. I mean, we've just been doing that test more recently, but most of them do have anti-PLA2R antibodies, and those are actually a risk factor for recurrence. There was a recent paper published just in the last month or two from our group in transplantation that talks about treatment and everything. If you're interested, I can give you that reference.
You want to expand a little bit on the role of anti-PLA2 receptor to determine whether it's recurrence or whether it's a de novo?
Okay, yeah, so some people have looked at that because you can get de novo membranous glomerulonephritis, especially late post-transplant, 5 years or more, and especially in patients who have features of chronic humoral rejection or who have donor-specific antibodies. So PLA2R, you can do PLA2R testing either by serum testing, or you can stain the kidney biopsies for PLA2R, and that can determine if it's if you have evidence of those antibodies, and that suggests a primary membranous glomerulonephritis. In de novo membranous glomerulonephritis, those are not associated with the PLA2R antibodies.
Yaki?
I have two questions. You mentioned in early recurrence membranous nephropathy, there was no food process effacement.
Mm-hmm.
How do you define food process effacement? I wonder had they used a morphometric approach, probably you would have found the food process widening.
Yeah.
So conceptually, it's just I cannot believe there was no food process effacement.
Mm-hmm.
So maybe what you meant was just grossly, there was no effacement. Probably that's what you meant, I think.
Yes.
You want to summarize?
So, okay, so what do we mean exactly by foot process effacement? Sometimes people call it foot process fusion or widening of the podocyte foot process, but these are just, it's just the language that we use. It doesn't necessarily mean, exactly what's going on in the podocyte, but that's just the language that we use. But it would be, but he is mentioning, could we do any morphometric analysis of foot process, widening and measuring those foot processes? Yeah, I think that would be interesting to do. I mean, right now we just look at it and then we say what the percentage is based on the number of capillary loops that we are examining by electron microscopy.
Just one more is, our pathologist colleague, of course, they all use BAMF schema reading biopsies. Doing a protocol biopsy is one thing, reading is another. Now, in early protocol biopsy, do you think current BAMF schema is adequate? I'm talking late.
Okay. Well, so the question is, do you think current BAMF schema grading is adequate for early post-transplant biopsies? I'd just like to make a comment about that. The BAMF grading, the BAMF scores are they are meant really for clinical trials, and it doesn't equal a diagnosis. So as pathologists, we're making a diagnosis, so it's a little bit like you can have, the same BAMF score if you have acute cellular rejection, BK, polyomavirus infection, pyelonephritis, lymphoma in the kidney, like all these kinds of things can give you that. So that is really separate from the diagnosis. And, the BAMF grading, what am I trying to say? The BAMF grading is never really adequate to give you the diagnosis, so it's separate from the diagnosis. But I think it's fine for, looking at severity of rejection, if you have inflammation in arteries, for example, or C4D positivity, so that's why you can do that. So we have a database at Mayo with all the transplant biopsies and all the clinical parameters. So it's easy, it's helpful to search for biopsies with certain features by the BAMF scores. Look for interstitial fibrosis, arterial or hyalinosis, that kind of thing. So it's okay for those purposes, at any time post-transplant, but it's not adequate for conveying a diagnosis.
Mark? Okay, I have a couple of questions. First is regarding the membranous that occurs in the transplants. So C4D you're doing by indirect fluorescence, right? So it's a little more sensitive than the direct fluorescence for
Yeah, we just use a two-step method though. Like at Mass General, they use a three-step method and there's an additional amplification step. So, yeah, so it's not as bright as it was at Mass General. That's why I was sending my slides out there. When I first started working at Mayo, I thought there was a problem with our state.
But the question, what I was getting at, though, is have you looked at those cases then for IgG4? Because you would expect that IgG4 would not be activating complement, it might not show up.
Oh, in the membranous?
Yeah, the recurrent.
Oh, we tried doing IgG subclass staining in those, but we'd already done immunofluorescence on all of them, and there wasn't, there weren't enough glomeruli to be able to make any conclusions on that. But yeah, that's a good thought.
Yeah, and then the second question is regarding the mesangial sclerosis. If you stratify, diabetes is like one of the most common reasons for transplant. If you stratify those cases for diabetes versus non-diabetic recipients, what do the data look like in that case?
Oh, I think that's kind of what that graph was getting at. We see it in both, and I don't know, I don't know like the severity of it. I could certainly look into that. That'd be interesting. But we see it in both diabetics and non-diabetics.
Do you see any correlation with their immunosuppressive protocol, sirolimus versus?
That's always going to be the question. Are some of these lesions caused by, for example, calcium inhibitor toxicity or, steroids or something. But most of the patients, or almost all of them, have been on a calcium inhibitor. They're pretty much all on the same immunosuppressive therapy, or have been on for most of the time that they've had that transplant. So some of them have been switched later, to sirolimus if they had skin cancers or something, but it's hard to draw any conclusions based on immunosuppression because they're so similar.
And the term mesangial sclerosis will freak out the clinicians. So maybe proper term is mesangial expansion.
Yeah, mesangial sclerosis sounds more like a diagnosis, though. So, yeah, I agree.
Did you have a question?
Yes, thank you for the examples. You showed the protocol samples with the workup of IF and EM. Does that mean that all protocol biopsies are subjected to the same workup of primary diagnosis in terms of IF and EM?
It depends on several factors. If the patient had a history of an immune complex glomerulonephritis in the native disease, something that could recur, or something like amyloidosis or something in the native kidney, anything that could recur, then we do the light microscopy, immunofluorescence, and electron microscopy on all of those protocol biopsies. If it's a conventional transplant, someone just had a history of diabetes, we wouldn't be expecting anything, then we usually do light microscopy only. We save a piece of tissue for potential immunofluorescence. In case we see anything abnormal on light microscopy, we think we should do immunofluorescence, or if the patient has proteinuria or something like that, then we'll do immunofluorescence on those. And we can always deparaffinize tissue for electron microscopy.
So you have your own triaging protocol with criteria, so the lab personnel can direct the case or hold or...
Yeah, so it's the person who orders the biopsy up front, they're in our transplant database with a certain indicator, and that helps them decide, which tests to order. And we've come up with an algorithm based on the primary disease or based on any, de novo glomerular disease, what subsequent biopsies what studies they should have. So that prevents not only, this algorithm prevents not only not ordering electron microscopy, for example, when we should have it, but it also prevents over-ordering, like doing more tests on patients who really don't need all those tests.
Yeah, going back to Mark's question about that in members, if you look at native native members, as you mentioned, IgG is predominant, C3 can even be negative. But interestingly, if you stain those for C40, C3d, both are positive. So
in the native kidney?
the native
Yeah,
kidney.
C40 is
Yeah,
positive in
also
the native
C3d
kidney. Mhm.
also.
Okay, we
Yeah,
haven't
so
stained for
that's very
C3d.
interesting.
Yeah,
And anyway, but C1q you rarely see.
right.
So one of the postulations of IgG4 activates lectin pathway.
Yeah,
That
exactly.
is the postulation, I think.
Mm-hmm.
But it's interesting, C3d is also as common as C4d.
Okay.
It's a lot more sensitive than C3. Antibody we're using is like a C3c anyway. So
Mm-hmm. Yeah.
Other than body mass, would you make some more speculations as to the cause of the increasing glomerular sclerosis and mesangial sclerosis over that 5 to 10 year period? Because it seems
Yeah.
specific to that 5 to 10 year period.
Yeah, so, there's mesangial sclerosis, and what often goes along with that is glomerulomegaly. Glomerulomegaly may be present with or without mesangial sclerosis and vice versa. I think besides body mass index or diabetes, I think much of it also might be due to this is one kidney.
Right.
It's single kidney in someone who normally would have two kidneys. So that's additional, I guess you could say, pressure on that kidney, pressure on those glomeruli, so then they become hypertrophic. So I think that's probably
Yeah.
what's going
in
on.
non-transplant, obesity-related if you do a kidney biopsy, they all have a big lump. What does mesangial look like?
Well, a little bit of mesangial sclerosis with obesity in native kidneys, a little bit usually, not as much as we're seeing here. So.
Well,
You show a similar rate of progression in a younger age donor.
You know, that's an interesting question. I haven't looked at that, but
what was the question?
I will look at it. Oh, sorry. The question is, do you see a similar kind of progression in a younger kidney donor? That's a very interesting question. You know, the age of the donor really affects how that graft survives, especially like we've seen with acute cellular rejection. Older kidneys from older donors don't respond as well to injury, it seems, as kidneys from younger donors. But I haven't looked at that. That's an interesting question, so I'll look at that.
Other questions? I know there's another meeting in this room, so we will end the presentation. Again, Lynn, thank you again.
Okay, thanks.